Hello everyone, my discussion topic is temporomandibular joint. First we'll proceed from the introduction. The temporomandibular joint is that which connects the mandible to the skull and regulates mandibular movement. It is a bicondylar joint in which the condyles located at the two ends of the mandible function at the same time. Now the synonyms. It is also called as diarthroidal joint because of the discontinuous articulation of the two bones allowing freedom of movement. It is also called as synovial joint because lined on its inner aspect by synovial membrane which secretes synovial fluid. It acts as a joint lubricant and supplies the metabolic and nutritional needs of the non-vascularized internal joint structure. It is also called as compound joint, composed of four joints, articular facets of the temporal bone and of the mandibular condyle and the superior and inferior surface of the articular disc. It is also called as gynecoarthroidal joint because articular disc divides the TMJ into two compartments. Lower compartment permits hinge motion or rotation and hence it is termed as gynecoid, and the superior compartment permits sliding or translatory movement and is therefore called as arthroidal. As a result, the TMJ as a whole can be termed as gynecoarthroidal joint. It is also called as bilateral diarthroidal because right and left both function together. There are few peculiar features of the TMJ, like the articular surface of the TMJ is covered by fibrocartilage instead of hyaline cartilage. Fibrocartilage is considered as a growth center for the mandible, only joint of the human body having rigid end point of closure, and it is the last joint to start developing in the 7th week of intrauterine life. Embryology. 16th week, articular disc appearance. 7th week, mecal cartilage extends all the way from the chin to the base of the skull. 12th week, condylar growth first appears. 13th week, the condyle and articular disc have moved up into the contact with the temporal bone. 22nd week, mecal cartilage degenerate. 23rd week, mecal cartilage transfers to anterior ligament of malleus and sphenomandibular ligament. Now the components of the TMJ, they are condyles, articular surface of the temporal bone, capsule, articular disc and ligament. Articular portion of temporal bone is composed of three portions. The largest is your articular or mandibular fossa, second is your articular eminence and third is your preglenoid plane. Now the mandibular fossa. The squamous portion of the temporal bone is concave. Anterior, a convex bony prominence or articular eminence. Posterior is squamo-tympanic fissure, anteromedially petrosquamous fissure and posteromedially petrotympanic fissure. Now the posterior roof of this is thin, so not designed to sustain heavy forces in which condyle is situated. The articular eminence consists of thick dense bone to tolerate such forces. The steepness of the articular eminence surface detect the pathway of the condyle. Now the condyles. The mandibular condyles are posterior portion of ramus of the mandible that extends upward. Mediolaterally, it is 15 to 20 mm and anteroposteriorly it is 8 to 10 mm. Now, orientation is 10 to 30 degree with the frontal plane. Medial pole is more prominent than lateral pole and articular surface of the posterior aspect is more as compared to the anterior aspect. In the frontal view, articular eminence often is concave and fits roughly to superior surface of the condyle. Bony surface of the condyle and articular part of the temporal bone covered with dense fibrous connective tissue with irregular cartilage like cells. The number of cells increases with age and stress on the joint. Now we'll talk about the articular eminence. In the articular eminence, first is present on the anterior to the glenoid fossa, consists of a descending slope, transverse ridge that is medial extension of the zygomatic tubercle and an ascending slope. The eminence is covered by the dense compact fibrous tissue that consists primarily of collagen with a few fine elastic fibers. Now the articular disc, it is biconcave oval structure interposed between the condyle and the temporal bone, consists of dense collagenous tissue that is avascular, hyaline and devoid of nerve tissues in the central area but has vessels and nerves in the peripheral areas. Divide into three regions in the sagittal plane, that is intermediate zone, posterior and anterior. Articular surface situated in the intermediate zone. Now the anterior view, disc thicker medially than laterally. Shape of the disc is determined by the morphology of the condyle and the mandibular fossa. Now during the movement, the disc is flexible to some extent and can adapt to the functional demands of the articular surface. The disc maintains its morphology unless destructive forces or structural changes occur in the joint. If these changes occur, the morphology of the disc can be irreversibly altered, producing biomechanical changes during function. Now the attachment of the disc, retrodiscal tissues, it is posterior attachment, highly vascularized. Superior retrodiscal laminas are elastic fibers and inferior retrodiscal lamina are collagenous fibers, remaining large venous plexus which fills with the blood as condyle move forward. Now, anteriorly superior and inferior attachments of the disc is capsular ligament. Superior attachment, articular surface of temporal bone. Inferior attachment, articular surface of the condyle, composed of collagen fibers. Between the capsular ligament attachment, there is superior lateral pterygoid muscle. Capsular ligament attachment medially and laterally and also divide the cavity into two. Superior cavity, it is formed by the mandibular fossa in the superior surface of the disc, and inferior cavity by the mandible condyle and the inferior surface of the disc. The internal surface of the cavity are surrounded by the specialized endothelial cells that forms a synovial lining. This lining, along with a specialized synovial fringe located at the anterior border of the retrodiscal tissue, produce synovial fluid which fill both the joint cavity. That's why the TMJ is also called a synovial joint. Now, synovial joint has two purposes: medium for providing metabolic requirements to the non-vascular articular surface of the joint, and it also lubricate between the articular surfaces during the function. It has two mechanisms by which synovial fluid lubricates. One is your boundary lubrication and second is your weeping lubrication. In boundary lubrications occurs when joint is moved and synovial fluid is forced from one area of cavity into the other, and the synovial fluid located in the border or recess area is forced on the articular surface, thus providing lubrication. Next is your weeping lubrication, refer to the ability of the articular surface to absorb the small amount of synovial fluid. During function of a joint, forces are created between the articular surfaces. These forces drives a small amount of synovial fluid in and out of the articular tissues. This is the mechanism by which metabolic exchanges occur. Under compressive forces, therefore, a small amount of synovial fluid is released. This synovial fluid acts as a lubricant between the articular tissue to prevent sticking. Weeping lubrication helps eliminate friction in compressed but not a moving joint. Only a small amount of friction is eliminated by weeping lubrication. Therefore, prolonged compressive forces to the articular surface will exhaust the supply. Now, we will go with the innervation of the TMJ. Most innervation is provided by the auriculotemporal nerve, as it leaves the mandibular nerve behind the joint and ascends laterally and superiorly to wrap around the posterior region of the ligament. Additional innervation by deep temporal and mesenteric nerve. Vascularization of the TMJ: superficial temporal artery from the posterior, middle meningeal artery from the anterior, internal maxillary artery from the inferior, and other important arteries are the deep auricular, anterior tympanic and ascending pharyngeal arteries. The condyle through a narrow space by the way of the inferior alar artery. This is how it is being referred, like anteriorly there is presence of joint cavity, inferiorly, posteriorly, superiorly. What are the structures we come across? Now we will proceed towards the ligaments. Ligaments plays an important role in protecting the structure. The ligaments of the joints made up of collagenous connective tissue which do not stretch. They do not enter actively into the joint function but instead act as a passive restraining device to limit and restrict border movements. They are divided into two types. One are functional ligaments and the second is accessory ligament. Functional ligaments are collateral, capsular and temporomandibular ligament, and two accessory ligament, that is sphenomandibular and stylomandibular. Now first we will move towards the functional ligament, in which we will study about the collateral ligament, which is also called a discal ligament. Attach the medial and lateral border of the articular disc to the poles of the condyle, commonly called a discal ligament, and it is divided into two, medial and lateral. Medial discal ligament attach the medial edge of the disc to the medial pole of the condyle, and lateral discal ligament attach the lateral edge of the disc to the lateral pole of the condyle. These ligaments are responsible for dividing the joint mediolaterally into the superior and inferior joint cavities. The discal ligaments are true ligament composed of collagenous connective tissue fiber, therefore they do not stretch. They allow the disc to move passively with the condyle as it glides anteriorly and posteriorly on the articular surface of the condyle. Thus, these ligaments are responsible for the hinging movement of the TMJ, which occurs between the condyle and the articular disc. These ligaments has a vascular supply and are innervated. Strains on these ligaments produces pain. Next, we will read about the capsular ligament. The entire TMJ is surrounded and encompassed by the capsular ligament. The fibers of the capsular ligaments are attached superiorly to the temporal bone along the border of the articular surface of the mandibular fossa and articular eminence. Inferiorly, the fibers of the capsular ligament attach to the neck of the condyle. The capsular ligament restrict any medial, lateral or inferior forces that tend to separate or dislocate the articular eminence. One significant function is that it encompasses the joint, thus retaining the synovial fluid. Capsular ligament is well innervated and provide proprioceptive feedback regarding position of the movement of the joint. Now the next is your temporomandibular joint. The lateral aspect of the capsular ligament is reinforced by strong tight fibers, that are the lateral ligaments or the temporomandibular ligament. Temporomandibular ligament has two parts. One is your outer oblique part and inner horizontal portion. Outer portion extends from the outer surface of the articular tubercle and zygomatic process posterior inferiorly to the outer surface of the condylar neck. Inner horizontal portion extends from the outer surface of the articular tubercle and horizontally to the lateral pole of the condyle and posterior part of the articular disc. Oblique portion resists excessive drooping of the condyle, limiting the extent of mouth opening. During the initial phase of opening, the condyle can rotate around a fixed position until the temporomandibular ligament becomes tight, as its a point of insertion on the neck of the condyle is rotated posteriorly. When the ligament is taut, the neck of the condyle cannot rotate further. If mouth will be opened wider, the condyle has to move downward and forward across the articular eminence. Clinically tested, by closing the mouth and applying mild posterior force to the chin, jaw easily rotate until teeth are 20 to 25 mm apart, after which a resistance is felt when the jaw is open wider. This resistance is brought about by the tightening of the temporomandibular ligament. The unique feature of temporomandibular ligament which limits rotational opening is found only in humans. The inner horizontal portion of the temporomandibular ligament limits posterior opening of the condyle and disc. When force applied to the mandible, it displaces the condyle posteriorly. The portion of ligament becomes tight and prevents the condyle from moving further into the posterior region of the mandibular fossa. Hence, it protects the retrodiscal tissue from the trauma created by the posterior displacement of the condyle. Also, it protects the lateral pterygoid muscle from overextension or overlengthening. The effectiveness of temporomandibular ligament is demonstrated during case of extreme trauma to the mandible. In such cases, the neck of the condyle is seen to fracture before the retrodiscal tissue serve. Now we will study about the accessory ligament, in which we will first study about the sphenomandibular ligament. It is a accessory ligament of the TMJ, arises from the spine of the sphenoid bone and extend downward to a small bone prominence on the medial surface of the ramus of the mandible called the lingula. It does not have any significant limiting effects on the mandibular movement. Now the stylomandibular ligament, it arises from the styloid process and extend downwards and forward to the angle and posterior border of the ramus of the mandible. It becomes taut when the mandible is protruded, but it most relaxed when the mandible is open. The stylomandibular ligament therefore limits the excessive protrusive movement of the mandible. Now the surgical anatomy. In this, the main trunk of the facial nerve exists from the skull at the stylomastoid foramen. The suture line between the tympanic and mastoid portion of the mastoid bone is a reliable anatomic landmark because the main trunk of the facial nerve lies 6 to 8 mm inferior and anterior to this tympanomastoid suture. Approximately 3 cm of the facial nerve is visible until it divides into temporofacial and cervicofacial branches. In the classic article by Kyatt and Bramley, the distance from the lowest point of the external bony auditory canal to the bifurcation was found to be 1.5 cm to 2.8 cm, and the distance from the postclinoid tubercle to the bifurcation was 2.4 cm to 3.5 cm. The most variable measurement was the point at which the upper trunk crosses the zygomatic arch. It ranged from 8 mm to 35 mm anterior to the most anterior portion of the bony external auditory canal by incising the superficial layer of the temporalis fascia and periosteum over the arch inside the 8 mm boundary. Surgeons can prevent the damage to the branches of the upper trunk. Now the relations. You can see anteriorly there is mesenteric artery, lateral pterygoid muscles. Now laterally there is skin, parotid gland, temporal branch of the facial nerve. Inferiorly there is maxillary artery. Now the temporomandibular joint and external aortic meatus are separated by parotid gland. Superiorly there is a middle meningeal artery and middle cranial fossa. Medially there is TMJ. TMJ is separated from internal TMJ. Then there is a separation by ICA through a tympanic plate. Then there is a sphenomandibular ligament, middle meningeal artery and cauda tympanic nerve. Posteriorly there is a superficial temporal artery. These are the surgical approaches, that is pre-auricular, then modification is Blart, Thoma, Kyatt and Bramley, Popwich modification of Kyatt and Bramley's, endural approach, post-auricular approach, submandibular, or which is also called as residence approach, post-ramal or Hind approach, hemicoronal approach or bicoronal or coronal approach. Thank you so much.